Hello, my name is Jay Fallon. It's my privilege and pleasure and honor to be the Executive Director of the New England HIDA. Before I introduce our next presenter, I'd like to share with you some of the prevention work that we've been doing over the years here at New England HIDA. We view prevention as an absolutely essential complementary strategy to reducing drug trafficking. We believe in building a strong foundation for youth to propel them towards a bright future free of drugs. Therefore, 12 years ago, we partnered with the Essex County, Massachusetts Sheriff's Department to help sponsor a youth leadership academy. This academy works with at-risk youth in cities throughout the county. Prevention is an important pillar in the New England HIDA overall strategy as we strive to build safer and healthier communities. Additionally, New England HIDA has invested in the Safe and Competent Opioid Prescriber Education Program, known by the acronym SCOPE, sponsored by the Boston University School of Medicine. This program, in which prescribers educate other prescribers relative to the danger of long-term opiate use, has successfully resulted in a drastic reduction of both licit and illicit opioid use. I'm quite proud to say that our Youth Leadership Academy program, as well as our SCOPE partnership, has resulted in both entities having been recognized as National HIDA Award winners. It is now my pleasure to introduce our next presenter, Beth Connolly. Ms. Connolly serves as the Assistant Director of the Office of Public Health within the White House Office of National Drug Control Policy. In this role, she oversees the development and implementation of public health approaches to reducing drug use and its consequences, focusing on prevention, harm reduction, treatment, workforce and recovery-ready workplaces, and recovery support services. Ms. Connolly brings to ONDCP decades of public health and human services experience in both government and nonprofit sectors. For 30 years, she served in the New Jersey Department of Human Services, concluding her state government career as the department's commissioner. Her government experience includes serving people who are often underrepresented and face social challenges such as homelessness and lack of health care. During her tenure, she shepherded reforms related to behavioral health, Medicaid and its expansion, safety net programs, child welfare, and the adoption of home and community-based support services. After leaving state government, Ms. Connolly joined the Pew Charitable Trusts. There, she directed the Substance Use Prevention and Treatment Initiative, leading research and technical assistance efforts across the federal government and states to promote evidence-based transformation of the treatment system, expand the substance use disorder workforce, optimize coverage and reimbursement for effective treatment, and improve the delivery and coordination of care for underserved populations. Ms. Connolly also served as an adjunct professor in graduate programs at Seton Hall University, Rutgers University, and Georgetown University. On behalf of the New England HIDA, we would like to thank Ms. Connolly for being here today as she shares ONDCP's approach to prevention and suggests guidance for implementing public health policies. Thank you very much.
All right, thank you, Jay Fallon, HIDA Director for New England HIDA. So we're sitting here in the Office of National Drug Control Policy. They are hosting our HIDA Prevention Summit. And we thought it would be kind of neat to have an informal conversation with Beth Connolly, who you've just heard about her vast experience in the field of public health. But we thought it would be kind of nice to just sit down and have what we're calling a fireside chat without the fire and just kind of talk through ONDCP's approach to prevention, but also just get a sense of how they think about public health and any activities that they're engaged in related to this topic. So here you have us seated here in hopefully a very comfortable spot. Are you comfortable?
Yes, definitely.
Okay. All right, good. So we're just going to dive in to this major umbrella of public health. And Jamie had mentioned earlier the public health, public safety framework that National HIDA program has developed and that we sit under. But let's just talk about public health as a concept through your eyes. When we think about a public health approach in any context, what do we mean?
Well, thank you. And I think that's a great question to kick this all off. First, I want to say thank you to Jay. Having been born and bred in New England, happy to hear from you, and thank you for your kind introduction. And thank you, Laura, and everybody at the HIDA for sponsoring this really, really important summit today. I'd also like to take one quick opportunity to thank all the folks who tune in, because the work that you do is really important. As maybe Dr. Jones had provided some data earlier, we know that in the 12-month period ending in May 2023, we saw 112,000 overdose fatalities, and it's staggering. So the work that you all are doing on the ground is really critical, and the support that we all need here at ONDCP is your continued collaboration. So thank you. So, talking about a public health approach more broadly, and, thinking about it in many different contexts, we want to always think about all the different aspects of someone's and a community's health and well-being. And as we think about this, we need to take in like a multidisciplinary approach, bringing in all of the ideas of the society, of the environment, of the community, and how all of these pieces play together in any problem that we're trying to solve. So the public health we want to think about health, we want to think about safety, and we want to think of well-being of an entire population. And how do we get to that end? So we want to think about the steps involved in a public health approach to anything. So the first thing we want to always think about is, what is the problem we're trying to solve? And it's really important to ask ourselves and to think about, what is the problem we're trying to solve? I think if you put a lot of different people in a room, you might have a lot of different answers. Right. So oftentimes coming to a public health solution to a problem is really being able to articulate the problem and understanding that we all have the same actual understanding of what this problem is. Mm-hmm. And then we need to know what kind of data do we have on this, on whatever it is we're trying to think about with a public health lens. And not only the data that we have, but what's the data that we don't have? Because that's very telltale in how we can go about addressing a problem, looking at what's available to us and looking at and thinking about what's not available and what would be great to know. And, this also means gathering our stakeholder groups. And, a multidisciplinary approach means, a wide breadth of folks that come from different backgrounds and different spaces. And, I often talk about the usual suspects and the unusual suspects. So in the substance use prevention space, you would think about, the provider community, the community of people who are seeking services, the community of people who use services. But as we think about a public health approach, we need to also expand it out to think about other populations, other disciplines that may have a point of view or a perspective, and bringing those to the table to help understand the problem and to help us arrive at an intervention. One of the key stakeholder groups to bring in any public health discussion are people who are experiencing whatever it is we're trying to solve. They have a unique perspective. And as much as me with my, thank you, Jay, decades of experience, and many of you with your, lots of experience in this field, we don't necessarily are able to articulate what the needs are of the person who is experiencing the problem we're trying to solve. So it's really key to make sure that those voices are at the table. And I'm sure I don't have to, this is probably just, preaching to the choir, but, oftentimes it seems we sort of think of these folks as a last minute addition, but bringing them to the table early, making sure that we can really understand and get their perspective, because at the end of the day, they're going to be, experiencing what we're trying to solve for. After we have brought these groups to the table, it's time to design interventions. And, one size does not fit all. Every community is different. So thinking about, in the context of the environment, of the community, of the stakeholders that are there, these are really important considerations when we are designing an intervention. Then we have to implement the intervention. And implementing the intervention is, is it evidence-based? Are we implementing it with a degree of certainty of how it should be implemented? And after that, to me, one of the keys in the very beginning, the definition, and making sure we have the right people at the table, but then the evaluation. And oftentimes, the evaluation gets left out. And we end up with thinking that we've designed this, we've used all the evidence, we've talked to all the right people, we have the data, and we really feel confident in the solution we are that we're implementing, but we fall short of evaluating it. And the only way we know that we have a successful evaluation is in that evaluation stage. And sometimes this is the hardest part because oftentimes there's not as much money for an evaluation process as there has been for maybe implementing whatever it is the strategy that we're implementing. And so evaluation is really key so that we can say, we can replicate this in other communities. We know this works, or as very important, we know this doesn't work. Because sometimes we can design the best intervention with a lot of data, and we have to figure out, where did it fail? At what point should we have made a course correction so that we won't perpetuate a solution that's not going to be effective? Because at the end of the day, we're caring for individuals. We want to make sure that what we're doing is really pushing forward the evidence-based solutions that we're seeking.
A lot of additional sub questions coming up. I'm going to ask just two.
Mhm.
Let's run with the one that you were just speaking about. The importance of evaluation related to wanting to replicate things that do work and that don't work. But can you speak at all also to the importance of not replicating those that even can cause unintended harm, those unintended consequences? That's one of our main messages for the summit. And we're getting our heads around through the summit how to think beyond that traditional way of thinking about evaluation with, did it work towards my intended goals, right? To achieve what I wanted to achieve, or did it not? But then also, did anything iatrogenic or harmful occur? Is something I didn't want occur? Can you talk about that?
Sure. So when we think about this, again, in the beginning of the process and the end of the process, it's really important to make sure that we've brought in all the different folks, right? So we have evaluators, but have we actually reached out to the communities and talked about the consequences, positive and negative? So the people who are receiving whatever solution is we're trying to implement, and then others in the community. Again, we want to keep away from this very narrow focus of I am a recipient of this intervention, what happened to me, but what happened in the community, larger community at hand, and how have they been seeing this? What are their perceptions looking in? These are really key insights that folks maybe don't think about because they're very concerned about the individual who can speak to what their experience is, but also there'll be an experience that's more broadly felt. Some things as simple as like a satisfaction survey are often very informative for folks, and in some places they give us that little piece that helps us tease out the next question to ask. So as you have figured out some of the next questions to ask me, we have to also think about what is that next question. We have maybe a very academic approach to evaluation, but what are these next questions that we should also be asking in terms of how this has impacted the community?
Thank you for that. And something you mentioned earlier regarding the public health approach and that second step of recognizing the data we do have and can leverage, right? And the data we don't have. If you had to just off the top of your head, lean into that question around what don't we have that really could be useful right now for ONDCP's approach, for our approach, at the ground level. is there something that immediately pops to mind in terms of the types of data that we could be thinking about collecting?
Sure, and let me give you a real life example of something that happened here at ONDCP. You know, when you think about overdoses, we have data on fatalities. But, you know, realizing that, you know, depending on who you ask, and depending on the research that you use, there are, you know, 7 to 10 non-fatal overdoses before a fatal overdose. And in our thinking of how do we approach bringing evidence-based programming of any sort, prevention, harm reduction, treatment, recovery, into a community, thinking about the non-fatal overdose data is really critical. And it also helps the community realize, you know, where are overdoses happening, you know, and not just fatal overdoses, but non-fatal overdoses. You know, is it a particular population? Is it a particular part of the community? All of this, and so we developed actually a non-fatal overdose data dashboard in our Office of Translational Research to help guide our thinking and help guide the thinking out in the community. So, you know, we saw a problem and now we're using that and we keep improving on it because I and others keep asking more questions of that particular data. And so how we're looking to ways to expand it, and recognizing that not every non-fatal overdose is reported. You know, some people are reversed using an opioid overdose reversal medication. They never make it to an EMT. They never make it to a hospital, and they just are revived, and it's never reported. So, you know, now exploring how do we get this additional data so we actually know how many non-fatal overdoses there are. So it's a continuing process.
Wonderful, thank you. And we, you know, I sit within the Washington-Baltimore HIDA, and something that we consistently think through is ODMAP is stationed there, and the non-fatal overdose information and just all the information that's being entered into that application, we are thinking through as prevention professionals, how can we use that with the hot spots, right, that are being identified in those early response strategies that are being deployed, right? Like what is our role from a prevention lens in helping with that? So that's been on our minds, just like you said with the other program, right? That's the type of data that maybe we could be looking at. And more importantly, thinking through what to do with it, right? How to use it meaningfully. All right, what are ONDCP's prevention goals and how are they being measured?
Okay, so ONDCP is responsible for the President's National Drug Control Strategy. And, you know, the President has made clear in his unity agenda that the overdose epidemic is really, you know, is a key pillar and something that, you know, we need to take serious action on. And so the National Drug Control Strategy is a comprehensive look, a public health lens look, if you will, across the supply side, across the demand side, bringing together 2,000 stakeholders with vast experience, including people with lived experience, to actually help and give input into the design. So a public health approach really taken in every single part of it. It comprised of many chapters: prevention, harm reduction, treatment, workforce, recovery, criminal justice, data, and then a set of chapters on the supply side and supply side reduction. And so this broad framework, then in terms of the prevention, there are a number of principles in each chapter. So the principles under prevention, and just so I get them exactly right, let me read them, are preventing substance use among school-age children is effective. Preventing substance use among young adults protects overall health, and preventing youth substance use requires community-level interventions. And so as we think about all of these, we realize that these are really three different approaches. As we think about identifying the risk and protective factors of children, you know, K through 23, 24, 25, you know, these are very different protected factors that, you know, they evolve over time for children, as I don't have to tell any of you because you are all the experts in this area. And so how do we then recognize these things and then build into these principles some things that can be implemented that will be appropriate and will address these very particular needs. We also have to recognize that risk and protective factors, cover a lot of different populations for children. So are their peers, their families, their schools, their communities. It's broad. And so, making sure that as we think through these principles and think through the action items within these principles, that we have brought these to the table. So, when we think about kids who are K through 12, we think about education settings, or we think about, family settings. We also think about research, expanding research into this age group, but as well as the other age groups. In the way that I talk about evaluation often lags, research itself often lags. And so it's really important that we do have research specific to different age groups. We think about the next group, a little older, right? 18 to 23, 24. As they're transitioning from, this childhood, adolescence into adulthood, how do the coping mechanisms change? How do they need to change? And what's our approach when we think about talking to them and presenting to them and implementing programs that really talk about their health and their well-being as they, go into adulthood? And how are we looking at that? So thinking about, universal screening, thinking about screening, for this age group that maybe it has to, it really is screening, generally speaking, in all age groups has lagged, except in certain specialized professions. So how are we thinking about, looking at this for this population? And then when we think about the community level services, what are those strategies? And our drug-free communities programs really are so key in having that community-based and community level impact and support as they know their community. They know what's going on. They watch their communities evolve, and they can take that information, they can take all of that experience, and they can help it drive with their community partners. And the partnerships are so key, right? Without those, we would sort of, again, as I was talking about all the stakeholders in the past, the community partnerships in this regard are also very important.
Yeah, I'm just thinking through these community level interventions, right? And how it's a focus of the National Drug Control Strategy and one of the principles. And I'm thinking through the document that one of the tools that you all are being provided on developing a community-based prevention strategy that's comprehensive. So a comprehensive community-based prevention strategy. And it's a tool, and honestly, Beth, it took a long time to put that together in a concise way, thinking through the 5 phases, thinking through the lessons that we've learned so far. So I'm wondering kind of if you had to give any advice related to developing a comprehensive community strategy for prevention, right? We've got a starting point for you in the 5 phases and the tool, but how would you respond to that question?
Yeah, I think that this is sort of experience in all the different places that I've been. First is that I think everyone often thinks everyone else has already done it, right? We don't necessarily recognize our role in the broader strategy. Sometimes we get into an area that we're kind of siloed.
Yes.
And not recognizing that we have what our role is in relationship to what else is being provided in the community is so important. And if you were to ask some folks in certain communities, I don't think they would have an inventory, even in their kind of head, like what else is being done in my community? Either I think I'm the only one, or somebody else here is doing something, somebody's doing something, but nobody really has brought people to the table to think about like, what is the inventory of things we are providing here? And are we coordinating them? Are we working together to the same end? So as I talked about in the beginning, you know, we have to define the problem. Sometimes when you sit everybody together, you say, what is the problem? And, you know, we all have a different answer. And so in the same way that we talk about the public health solution, we need to think, you know, sit down with our partners in the community and partners we may not think we have, and say, you know, what do you think is the problem? What do I think is the problem? And sort of come to a consensus so that we can all move forward. And maybe it's a few different problems and we have different folks doing what, but, you know, what do we all recognize that needs to be done in our community?
You just said that so beautifully, and that's one of our main messages for this summit that we're hoping people will take away from it, is that any new prevention intervention or any prevention intervention existing, right, needs to be integrated, not exist in isolation, but part of that, understand that big picture going on around them and their role, like you said, in the larger strategy. So thank you for that. All right, I'm gonna restrain myself from any other questions because I want to get to some of the juicy ones, right? So the work of prevention is hard. It's hard, and I think people often don't really just sit with that for a minute and recognize that there's not a one-off solution that can be implemented in 20 minutes or an hour, right? And then be done. So recognizing that, Captain Jones spoke to this a little bit this morning. He posed, can we reimagine or rethink prevention at this time? Leverage what's working, right? But do we need to maybe think through it in a slightly different way, considering the unpredictability and toxicity of some of today's substances? In your opinion, are there ways to assess and possibly rethink our approach to achieving our prevention goals? What do you think?
So I think prevention is hard. And I think you raise this great point, is everybody wants the solution that they can fix now. Like, how do, you know, we stop this now? I want it now. And there, you know, given probably a few outlying things, there is nothing that we can snap our fingers and say, here we go, here's the magic tool. And, you know, we can fix this and we'll see results, you know, next month. We'll see results. And, you know, in prevention, I think that's what frustrates a lot of folks on the outside of prevention looking in, is that prevention efforts evolve over time and they take time to see the results. Because, you know, if you think about, you know, starting with a child in kindergarten, you know, those results are something we're measuring farther along in their life cycle. Some things more immediate, some things more long-term. And so it's sometimes hard for people outside of this world, right, to grasp. So I think that, you know, and at the tail end of our previous conversation question about bringing together folks who've been in silos, you know, it's sad. And there's, and I'm probably going to misquote her, but Grace Hopper, who was a programmer, right? She was a computer programmer, the founder, the mother of programming. And she would say that, you know, the worst thing that you can do is say that this is the way we've always done it. And that, you know, just this is the way we've always done it, so we should keep doing it this way. And, you know, we do need to ask ourselves, how can we do it differently? And, you know, one of the things is, again, bringing people together and bringing in some of our unusual suspects. And, you know, this makes me think about, and it's not prevention related, but it's crisis related. When I ran all the social services and human services recovery after Superstorm Sandy in New Jersey, you know, we realized that there were folks who had designed some interventions and some plans to address the you know, things that would happen to residents when, you know, a social service sort of intervention or a plan. And those folks who had designed these plans never asked anybody in the community, you know, who did this work. So they never asked any mental health professionals, say, here's my plan, what do you think? They never asked folks, in substance use field, how about this? They never asked folks in the housing field, how about this? Folks who work in safety net programs. And so when Superstorm Sandy happened, people dusted off these plans and everybody's like, well, how come nothing is working? And it was because nobody had opined on the plans with any of the experience. And when you brought folks together, we finally brought folks together and we sat them all in a room. It was like an epiphany on, some of the emergency management and law enforcement side to hear the folks from, the social worker side, I will call it. And that was very telling about how these two groups had very different approaches and very different ways, but they had never come together. And so we spent a lot of time trying to rectify this in a very quick manner. The more interesting thing, because sometimes, if you come from a social worker kind of background, it's not uncommon that social workers and law enforcement, no offense to either side, but sometimes these have not been the closest partners in years. This is, just been, and so what did surprise me more, though, was the folks in the social service community who hadn't spoken to each other. And a good example, which I think translates into many things, is that we had many groups providing case management services to people impacted by Superstorm Sandy. And when I sat down with the people who were working with all these groups, they would say to me, well, my one case manager from this organization told me to do X, Y, and Z. Then the person from this organization told me to do A, B, and C. And then the person from the third one said D, E, and F. And just the fact that all these who are all supposed to be rowing in the same direction, were having this person, these individuals, confused, and then they were frozen. Yeah. And it was hard for them then to know what they needed or to how to move forward. And so, coming together and really, again, and I'm probably sound like I'm a broken record, but what's the problem and what's the solution and how are we each contributing to it with that person in mind, that that person that might be a conglomerate of different people, so that we don't freeze them in the middle because they don't know which way to go. Am I supposed to believe this curriculum? Am I supposed to think this what they're teaching me here? Because there's a lot that's going on in communities, right? People, from their schools, from their places of worship, from their community centers. And are we all, people are going to all these places, they receive input, and are we bringing them all to the table? And then, when you think about looking outside, and something that maybe this is sort of just like off my head, but the thinking about housing, right? What are we doing in terms of housing and how, in communities where there is a lot of multi-generational housing, where there is a lot of apartment buildings, so people are very community oriented, not so much disparate housing like in a rural community. How are we bringing in those folks that are developing different kinds of approaches to where people live and how people live, and how does that influence some of the thinking that I may do as the provider of a service? Yeah. So you're thinking about who else is in our community that we don't talk to. Yeah. I think that oftentimes is a place that we sort of just think we pick our usual suspects, we always talk to them, and that's where we sort of get in that place where we're just repeating everything that we've repeated in the past.
And I don't think you sound like a broken record at all. As a matter of fact, what was swimming through my head and hearing your response to that was going back to what you originally said around a common understanding of the problem, right? And I hesitate to use the word definition because the problem can often be very complex, right? So a common understanding of that problem, then also a common understanding of the approach that is going to address it, right? And getting everyone on board, making sure all those dimensions are covered. That really resonates, I think, and I don't think you're a broken record related to that. Okay, so we've got two more questions and I'm mindful of the time, so I want to make sure that we give you enough time? This is one that comes up over and over again with funding.
Yes.
Funding. We just had the question asked a couple of times with Captain Jones, right? Because SAMHSA,
Yeah.
right? SAMHSA is a huge funder
yeah,
of a lot
for
of
sure.
prevention initiatives. But talk to us a little bit about how can we access federal funding? Kind of your wheelhouse here, right?
Mhm.
How can we access federal funding to support our prevention initiatives? Talk us through that.
Sure. So as you all know, prevention happens locally, but the primary funding sources are federal.
Yeah.
And in between that, is state government typically. Most of our federal funds come to the states through the state government. And, then it's up to the state government to sort of figure out where these need to go. And one thing that was evident to me when I was, leading a department in state government is the folks that I knew and the folks that I didn't. And some groups, some organizations are very good at, making themselves known, and some are very quiet. And, it was always interesting is that people felt they needed to be invited to the table rather than asking for an opportunity to come to the table or to come to speak. And I think that is sometimes where we don't see folks who are, they may think like, I'm waiting for my invitation to come to the table to meet with the state officials. When I would speak broadly when I was in the state government is, come to me. I don't know who you are unless you come and tell me who you are. And the best way to come and tell me who you are and tell me about yourself is to provide me some data. And, folks are like, oh, no, we don't have like really great outcome data. We don't have this evaluation. But, you have a lot more data than you think you do. You know how you're spending the funds that you're doing. You have a lot of output data. You know how many people you're serving. You know the communities that you're reaching. You probably have some idea about the demographics of the folks that you're reaching, the age groups that you're reaching, like who are your partners? It was coming to me, as commissioner and as in the commissioner's office, it was always great to understand that it was much more meaningful to me as a potential funder from the state level to understand like who you're serving, where you reach, why your folks are underserved. Tell me about your community and the lack of resources because I'm interested in that. It's important to me to know that there is this community. I'm not saying that this is very easy because I get it. It's not. If you're especially, in New Jersey, we're a very populous state, but we're also pretty compact, in geographic ways. And this sometimes is where, again, creating partnerships is really important because if you can find a way to collaborate with some, you have another voice with you. So, maybe you're collaborating with a housing group. Maybe you're collaborating with on the mental health side. Maybe you're collaborating with law enforcement. And this gives you another voice to raise up to the funders who are receiving the SOAR grants or the block grants that SAMHSA is sending out, which they all go to the state, and then they're distributed at the local level. So who are some voices that you can partner with that will raise you up? And how are you packaging what you're offering to demonstrate that the good outcomes, or at least that you're touching a lot of people and that people are receiving your services and benefiting from your services. It's a difficult journey, and and I'm not saying that federal funds are easy. When you're applying for them.
Thank you for acknowledging that.
No, I've been on the other side. And so I know for a lot of small community organizations, applying for federal funds isn't easy. And oftentimes you're working on a shoestring. Again, finding a good partner sometimes who is a little bit bigger, but doesn't have a service that you really excel in that you offer. And how can you and the partner leverage the two of you to perhaps draw down more funding? I think sometimes of the continuums of care in the housing sector that have been increasingly looking at partnerships that are, not just housing provider partnerships, but, service provider partnerships. And, this, is HUD a place where maybe if I partner with, my continuum of care in my community, is this a place where, I can offer this service to them and, it's beneficial to both of us. It kind of expands my sustainability. It also gives me an attachment to perhaps, a bigger lever. The other place, lots of federal funds, but the opioid settlement dollars are coming down the pike, right? And, billions of dollars are coming into every state and some at the county level. So, we're talking about state and local dollars. They don't have the reporting requirements that some of our federal funds do. But they have to be used, the majority of them have to be used for, addressing the crisis. And so working in the states, most states have some kind of a group, a coordinating group, a coordinating council that's looking at how to distribute these funds. And this is another place that definitely folks should be looking at and finding out who are on these groups, what are they looking to fund, and how can I make my voice heard there? Because we are talking about billions of dollars over, a long period of time, that these will be really important funds that hit the ground.
Yeah. And what I hear in the back of my head are a lot of communities that we work with. It feels hard in terms of like you don't have direct access. And it's true, we don't. And you've just offered some strategies, right? And some may feel uncomfortable, like if it's a school-based organization, right? Or if it's a school itself, or let's say a community coalition, for one that may not feel comfortable finding that voice, right? Or directly with the state. I kind of like thinking through this, and I've heard from communities that, like, for instance, a school, and we had some questions come in about this earlier around, number one, how can I get buy-in into the importance of prevention in my school? But then how can I access some funds? And what I'm hearing from you is the federal level, that funding's trickling down through the states in large part, right? And the different ways in which you can draw that down, or at least present yourself and increase awareness that you're available and ready for the money, and have started actively working towards it. But what we've seen in some communities is the schools will tap into that coalition that may be existing in the community that represents the 12 sectors. And you've got 12 voices already on it, right? And that sometimes those coalitions then have access to another partner or direct access to the state, but maybe like a state level coalition partner, right? Like in Virginia, the Community Coalitions of Virginia, right? There's a state level association there then that might have access and already a voice with the state. So there are different ways of maneuvering, right? And what I'm hearing from you is try them all. Try them all, right?
And find a lot of times, if you can find a trusted partner, even if it is in a place that's unusual, if you think, HIDA is, public safety, public health, and, like thinking about like, what are the avenues through law enforcement that maybe I can manage, I can branch out there, like, who can I talk to who is in, if not a decision-making role, someone who can, actually has access to someone in a decision-making role. And it may be finding a person or a group that is not usually somebody who I partner with, but maybe we can come to talk about our common approach, or maybe they're looking for a prevention approach and nobody's coming to them to talk to them.
That's right.
Sometimes I feel like when back to my Superstorm Sandy analogy, when we talked to the folks in emergency management, they said nobody ever came to talk to us. I was like, oh, okay, thanks. And so, it was, nobody ever, they were chugging along thinking they were doing everything well. And they were like, nobody told us. And so sometimes, figuring out maybe, and it's, it probably sometimes, fall on deaf ears, but, maybe it won't. And so and it's work. Prevention is hard.
Great way to wrap that up. Right where we
I know.
began, right? That's so important, right? To just kind of emphasize, and communication
Yes.
is hard. Finding that
It is.
voice is hard. And thank you for the plug about HIDA. I should have said that, right? We've got HIDA prevention representatives in every HIDA. Every HIDA has identified at least one person that is that liaison to their approach to prevention, right? And maybe they are seen as unconventional if they're not actively engaged. And we know many communities just aren't familiar with that resource. Or partner is just a beautiful word for that. We do exist out there. So I'm not prevention point of contact for Washington Baltimore HIDA, but we've got Eliza Powell here from Northwest HIDA and Therese Hunter from Liberty Mid-Atlantic HIDA. They are the formal HIDA prevention representatives as well. So I think we're also going to be providing a list of HIDA prevention points of contact if you're interested in that. All right, let's conclude with, where are we headed? Where are we going next? The Office of National Drug Control Policy, you've got the drug control strategy. You've shared with us kind of the public health perspective, right? An approach coming out of ONDCP, but what's on the horizon? Where are we going?
So I think, looking ahead, I think we're moving in a really positive direction. And we have a lot of positive things that are working in our favor. One is, again, this identification of data, right? We're very focused on what other data do we need? Because this is going to support everybody in all of our approaches to kind of understand from a national level and then down to a local level, like what are the data that we're trying to get to everybody for our use and for everybody else's use. So I think we've never been in that position before. So we're identifying more, we're gathering more, we're pushing more out. Fantastic for everybody. One of the maybe only silver linings of COVID is the amount of research that we've seen happen in this substance use space in such a short period of time. And I always sort of like gut check myself with some colleagues and say, like, I've been in this space for a long time. Am I imagining that we've never had so much research in such a short period of time? And most Spartans, maybe some won't like text me later and say, no, I don't agree with you. But for the most part, they agree with me and say, yes, all of a sudden when COVID happened, and then we started to see the impact on, people receiving treatment, people receiving medications, how it was impacting our youth. All of a sudden, folks turned to start really studying what's going on and producing so much research that's really helping to benefit public policy. So, whatever happened in COVID, this little piece to me is so key because research is expensive. And, we don't see a lot of research in our space because folks never, there's a lot of stigma in our space. And that, it was, substance use is a moral failing. Substance use, was, your own fault, not anybody else's. And so now we're seeing this reckoning where folks are starting to understand, like, there's more to this than we've been knowing this whole time. And now we're investing into the research. We're, investing funds like we never have before. So increases in the SOAR grant, increases in the the president's proposed budget, so that we can invest more money, because these long-term consequences, long-term impacts are here, and we need to make sure that we address them. So with all this concentration, I think we're moving in a really positive direction.
This has been kind of fun. It's kind of like Inside Edition, Inside ONDCP, right? With this public health lens and approach. Thank you so much.
Oh, no, thank
you so much. Yeah, it was really nice to just sit and talk with you and get a sense of that way of thinking. And I hope that the audience has found this of benefit as well. And so at this time, we're going to see if there are questions. And Patty, I'm going to introduce you. Are you proud of me? I'm staying on time. All right, Patty Persizides is ADAPT's assistant director. And so she is often behind the scenes bebopping around, keeping us in line and making sure that we achieve what we have set out to achieve. She's going to address any Q&A that may have come.
Excellent. Thank you both. And there have been a number of inquiries that have come in. And Beth, you've spoken throughout the session today around the importance of data sharing, and even have highlighted in terms of sort of the plan ahead, how you need to think about what data you need. Well, there are a few questions that have come up specifically around this topic that I'd like us to start with. One is in particular about accessing youth substance use related data, not just substance use, but substance use and health behaviors, physical health conditions, and so on. So the question is mentioning how it can be challenging to get that information at a local level, and especially where a school may not be participating in any type of robust or ongoing or regular survey to capture that information. So the question is asking whether there might be any thought or initiatives at the federal level that might potentially require, say, school districts or school entities to administer some type of regular youth survey that would assess various behavioral and physical, emotional topics. Curious if this is something that you've heard about or could speak to.
I would, one thing, and perhaps folks know about this, one thing I'd point to is the Monitoring the Future report that comes out. A great source of data, NISDA, also another great source of data. If you're looking to something that's very community specific, I understand that's often something that is more difficult to achieve, because it does, mean, when you think about the very community level and the reporting and thinking about confidentiality and HIPAA concerns, it is often, one that that is difficult. In New Jersey, we did conduct some, but they were really initiated at the state level. Through for youth, looking at some of the youth feedback, one that required parental consent, or so there are some, but these really do tend to happen if you want really local data that can inform your local community. Oftentimes it is undertaken. I might suggest that you approach, a local university. Oftentimes they can have access to some de-identified data that might help you look at. So for example, in some states, some of the universities have agreements with the Medicaid program, and they have Medicaid claims data that they can look at, and they can sort of bring it down to, maybe not at an exact community level, but a little larger community level, to see what kinds of services people are receiving, and what kind of health problems that they're experiencing. And they can look at it, they can break it by age, and depending on whether kind of data is located in their Medicaid system. But again, it's de-identified, and it's gotten through a local university. In the spirit of research and evaluation, sometimes universities are eligible for grants that maybe a local community organization would not be, and they could tap into those for some kind of a specific community-oriented data gathering project.
Can I just add to that real quick? Because I can, in no means can speak to the federal policy and have control over that. But what I can tell you is, in working with communities, and many of them through ADAPT, there are a lot of schools, like starting from, because that was a top-down maybe question, right? But also thinking about it from the bottom up and going directly to the school, to the setting, like you alluded to earlier, right? That the youth are found in the schools, right? So maybe going directly to the schools to promote some buy-in and start asking questions around, is this possible? Because as you'll hear today in the afternoon session, we actually have that message and the tool that we're going to be releasing to you, that as you get higher and higher up, right, and expand that data set, right, to reach kind of state level youth and represent state level youth, substance use, it becomes less relatable, right, at the community level to those youth. So yeah, whatever we can do to support conversations, right, maybe through the coalitions with the schools who they have a school representative on them, to maybe have that conversation directly with the schools.
Thank you. A couple of questions have come up related to overdose related data. There's a lot of interest in the idea of accessing non-fatal overdose data. Aside from emergency departments, which for some are commenting that that can sometimes be a challenge to access, are there any other local resources you would consider folks look into for accessing non-fatal overdose data?
So, and I guess if somebody can share the link out to everybody so that you can look. It's a little bit higher level than very, very local, but ours is gathered through emergency management, EMT data, and so not necessarily, not specifically emergency rooms. So first responders, when they are at a scene, they're often a really good source, your local first responders, to get their insight and information about what they're seeing in this respect, because the first responders are on the scene. And then, definitely going into the communities and asking. So, but in terms of non-fatal overdoses, the ones that are reportable are reported. Many communities that I've spoken to have, set up really good programs and communications with their emergency management services and their EMTs and their first responders. In Washington, D.C., they have a project where they're alerted by first responders so that they can make sure that overdose reversal medication becomes available where we're seeing non-fatal overdoses and fatal overdoses. So make sure that they're back out there, the outreach groups, so that is, so they manage this partnership so that they really are getting informed by what's happening around from the people who are seeing it and experiencing it.
Thank you. And relatedly, another question came in about whether you could speak to some of the successes that have resulted through utilizing overdose fatality review boards.
So this is it's good. It's sort of like a social autopsy. We did not have, when I was in New Jersey, we were not doing that. I know the Director Gupta, in his capacity as the health secretary in West Virginia, they're very successful in using these as, these social autopsies as an important way, important way to address the specific needs of different communities. And so they found them, incredibly useful. These have, I think, not been around as long as some in the domestic violence community, where I was part of those review boards. But the reports and data that we would get from these were very, very helpful in looking across the community and figuring out what kinds of policies, what was working inside and what was not working. So using these types of review boards, was very compelling, and it did bring a lot of light into places where you didn't always see it.
Thank you. We have one quick comment and then one final question to conclude this session. You had mentioned that research and similarly evaluation can be quite expensive. And for many of those who are in communities and doing prevention related work, they understand the importance of evaluating for the impact that they're aiming to achieve. The question was really around, in terms of thinking forward, what data do we need? Might there be consideration for additional or supplemental evaluation-based funding for federal funded programs for whom those resources might be limited locally and prohibit their ability to engage in evaluation? So that was one comment that came out to share. I'll let you address that, to speak to that if there's anything under consideration currently, and then I'll switch to our final question.
I think, one of the pieces, that's coming that'll be easier to draw down perhaps for some community organizations than federal funds necessarily, are the opioid settlement dollars that are coming into states. It's billions of dollars coming down, and these dollars could be used to do evaluation, which is very important, especially in this climate and context. And so folks should definitely look to that area. And I'm, working with your academic community, oftentimes there are sort of grants from, lots of different sources that are available to them. And perhaps, I'm not speaking on their behalf, but perhaps they would really appreciate a partner coming to them and saying, if you can find this grant, we'd like to be your partner. And we'd love for you to work in this space with us. I know that there are some foundations that have made evaluation dollars available to groups, who partner with, a community provider who's showing has some positive view. Maybe it's just output data, but that partnered would be willing to partner with an evaluation, university or another academic kind of to go into an evaluation. And there are some foundations that are willing to fund that.
Excellent. And just our last question, you all have spoken to the importance of having a comprehensive prevention strategy in place within a community. So a question has come up around if we want to move upstream in our prevention efforts, how can communities help support the development or advancement of policies that address more community level type factors, things like parental leave, supportive, safe environments for youth, housing security, and some of those environmental and family-oriented type policies that we do know can be protective within that broader context of a comprehensive strategy.
So, the social determinants of health have, really become quite a talking point, and their recognition of how important they are in terms of health and well-being is much broadly understood than it was, maybe many years ago. Adverse childhood experiences as well. And as we're thinking about how we approach some of these things, it's really important to find this research and share it with your legislators, your lawmakers, share it with your governments who, everybody assumes that everybody knows, every bit of research that's happening out there. And I can tell you that, everybody doesn't know. And sometimes if you're sharing things that will make people think about how to draft a law, how to promote some evidence-based policy, you sharing research is really important. The other thing is comment. Lots of things go out for public comment. They're required by law to go out for public comment. Oftentimes, proposed legislation, both at the state and federal level, is available online. And, there's power in comment. There's power in written comments. There's really for folks to be sending in what they know, the evidence behind it, how they can make a law or a policy better based on some of the evidence that they know of and their experience is really important and powerful. And I know folks like to often go in front of, and make, speak at a public hearing. But the comments, and speaking from my role as a person who used to take in comments of this sort, being able to walk away and being able to read what folks have put together is so informative and really something you can keep going back to. So you're very powerful in your ability to comment on the things that are being proposed. And so you shouldn't ever think that you're not, because you have the experience, you have the knowledge, and to put it down and to provide it to someone, really can help change the course of policymaking.
All right, that was our last question. Beth and Laura, thank you so much. We've held people a few minutes into their lunch session, so we're going to go ahead and conclude here. Just so everyone's aware, you can go ahead and when this session ends, you'll be able to rejoin the subsequent session following lunch. And in the meantime, if you've missed any of the previous resources or materials, you are able to access those through the lobby. Through the lobby, you can also access any session surveys for previous sessions that you may have missed as well. At this time, we'll go ahead and conclude the session. Thank you all, and we'll see you after lunch.